Dear colleagues, I'm presenting an important topic. The title of the topic will be First Trimester Screening, 11 to 13 week scan after cesarean section. I'm presenting especially an important study which will change the field from my point of view from now on. We should look in a combined screening, combined approach also for the morbidly adherent placenta. This is a study from Dr. Panayotova from the Nicolaides group, which has been working for many years on that and fought for this study, and it's worth what she has done to look for. So individual care is what we want for ourselves, for our patients, which we like, but we should have all the individual care for every patient. We should treat every patient like our mother or sister and or our partner. So that's the goal, and we have shown for many things, for premature birth, preeclampsia, fetal growth restriction, that we can assess the risk, and also for potentially detectable abnormalities. We have seen in every pregnancy the risk is different, and actually the previous history is the smallest part, and also the maternal age is an important, but it's not the impact of the maternal age is reducing because every pregnancy is different, the body is changing, a woman can get healthier, a woman can get more sick, so she will have a different risk in every pregnancy. And that's what we have seen, for instance, for congenital abnormalities. If a woman develops diabetes, we will have a completely different risk for all the things where we have assessed the risk, for instance, the so-called potentially detectable defects using the method of review. There's a separate lecture on that. But if she has diabetes, which is pre-existing, the risk will be different for each condition. And also regarding gestational diabetes, the risk will be different, like you see in these odds ratios displayed above, or she will have a lower risk for all those things if she has not diabetes in this pregnancy, but perhaps had one in the last one. So we talk about early prediction of morbidly adherent placenta, which is a new term created by Professor Nicolaides, and I will explain why, most likely why he did that. And together with Dr. Panayotova, they had a prospective study, and they developed a combined approach to assess the risk, and it's an amazing prospective study. We really should look at these things from my point of view, and I also want to say thank you to Nuri Zosmer, one of the consultants of King's College Hospital, which I know has been involved in the study and has also done a lot of work for that. So what they did was a 12-week scan visit, and then patients with the criteria I'm going to explain were included or were followed up at the specialist clinic already at 16 weeks. So the criteria of each visit, and I just want to tell you there will be some slides with German text. I have been asked to prepare separated German presentations. I will kind of like have a mixed system. So because German is so close to English, and but I will explain everything in English, and some of the slides will be in German, but there will not be many. So the criteria of each visit were that a woman had a previous history of cesarean section, and the scar, the cesarean scar, was not possible to visualize, that the bladder wall was interrupted if you looked at it by ultrasound, and also the myometrial thickness was, if it was thin, was looked at, and they also looked for intraplacental lacunes and retroplacental arteriotrophoblastic perfusion and irregular placental perfusion. So the study design was a prospective study, more than 21,000 patients. They had a routine scan at 12 weeks. So it was a true screening study. And all the patients at 11 to 15 weeks with a low-lying placenta, criteria will be explained in a minute, and a history of cesarean section or myoma surgery were followed up. The definition of low-lying placenta differs. In Germany, some of the people use 5 centimeters distance to the internal os from the lowest part of the placenta. In UK, they use a more pragmatic, and I think the right one, definition, which means 2 centimeters distance to the os internum or internal os distance from the lowest part of the placenta. The results of this study were 14 cases. 14, they had the case of suspicion of a placental migration disorder. 13 finally had one. So, I mean, in a screening study, prospectively, more than 21,000 patients, only 14 patients were followed up, and of those, 13 had one. So there was only one positive. And that is amazing. I think we should really, this is the potential of this study shows that the confusion which will arise is on a minimal basis, and we should do it. Placenta accreta in the UK is used synonymously for, often, not always, placenta accreta, increta, and percreta. So, and I think the term Nicolaides introduced in the study is an amazing one, because it shows what is the potential of this placenta migration disorders. He calls it morbidly adherent placenta, or MAP. The consequences. Are there any consequences of a morbidly adherent placenta? Yes. Mortality is reported of up to 10%, morbidity up to 75%, so it's worth looking at it. And if we look at the different ways or different mortality and morbidity versions, we have firstly uterine rupture before reaching the survival goal. Most countries 24 weeks, some are moving a little bit more now again towards 22 weeks, but again we know there's a lot of even in this time period, a lot of chance that the baby will die or will have severe disorders because of the premature birth. Then also massive hemorrhage, multi-organ failure, and also emergency cesarean section. So those are the things which are the consequences, so-called morbidly adherent placenta. And it's actually now the most common reason for an emergency cesarean section. Risk factors are, we have already told, history of cesarean section and surgery of the uterus, for instance, of myomas, and placenta previa. So, and that's an amazing slide. There are individual risks in this study showing is 3% having a morbidly adherent placenta after having 1 cesarean section. After having 2 cesarean sections, the chance is 10%, a little bit more. After 3 cesarean sections, it rises up to 40%, and if you have 4 or more, the chance is more than 60%. Is it important to know it before the delivery if a patient has a morbidly adherent placenta? And the answer is clearly yes, because you can reduce, if you have a planned approach, a schedule, the morbidity by 50%. How does it look in normal fetuses? These are original pictures from the paper. You see here clearly the yellow arrow, which is showing the myometrial thickness, and also the placenta. It looks like it's completely separated in a retroplacental area where it's connected to the uterine wall. If you look suspicious, it looks like this. They defined it in that paper, in their study, that the retroplacental myometrial thickness has to be less than 1%. And you see it here. the bladder is visualized, the placenta, and you can not really say, okay, is there really a uterine wall using the B mode and using transvaginal ultrasound. However, you don't need to scan many patients transvaginally. You have seen that there were only 14 cases in this big screening study which had to follow up a high-risk situation. And yeah, so here you see a normal retroplacental venous perfusion. The bladder transvaginal scan again is directly to see there, and completely different in using color Doppler in those suspicious ones. And I think when we have Doppler, or you always have the problem that of course you need to have use the same presets, but this actually looks very convincing if you look at the pictures. And here you see a clear serosa bladder wall and a border. That looks fine. Placenta is very nice here to visualize, and uterine wall. So this is not suspicious. In the paper as normal. And if it looks interrupted, it looks like this. And you can clearly see this hyperechogenic line, the bladder wall, cannot be visualized properly. And if you look at vascularization, actually for me, from when I have discussed it with some colleagues, I think that's the most variable one. If you use power Doppler, I have learned the advanced techniques at Professor Gambro's unit, and we discussed that just recently at the ESWOG. Power Doppler, I think there's always a problem of a variability, and you especially with power Doppler, you have to have standardized presets. I might be old-fashioned, but that's my point of view. But in this study, they used normal vascularization like this, and they call this suspicious. Yeah, it looks here really amazing, but from a practical approach, I think, but it's just my personal opinion. In this study, they used it as a combined approach, and you will see why. Even my personal opinion, which has nothing to say from a evidence-based approach, even taking this into account, looking at the results, there's the impact relatively low. Having false positive rate, having a different opinion on that. So this is the study protocol, and you see 22,604 patients, and follow-up where, if you look at a specialist clinic, only 1,300, so 6%. Yeah, and then they were seen after for in a specialist clinic every 4 weeks. Yeah. So criteria of each visit I already have told. History of cesarean section, bladder wall interruption, thin retroplacental myometrium, intraplacental lacunes, retroplacental arteriotrophoblast perfusion, and irregular placental perfusion. The best marker, if you look at the meta-analysis, were retroplacental arteriotrophoblast perfusion and irregular placental perfusion. And the worst markers are, the intraplacental lacunes. If you look at the subgroup scoring, you see here why it's important to use a combined approach, and you see on the left ultrasound markers, and then on the lower left how many criteria were fulfilled by each patient. So the patients with a morbidly adherent placenta, they had always a score of equal of 4 markers. So and if you look at the other patients, there's only one which had 4 markers. So if you have 5 or 6 markers, you might have even a higher detection rate. But I showed you that some of them might have a variation. But this is very, very promising. Yeah? And in the no Previa group, no patient had more than 2 markers. So we have almost a clear separation using this combined approach. If you look for those things such as intraplacental lacunes, myometrial thickness, retroplacental arteriotrophoblast blood flow, irregular placental vascularization using 3D power Doppler, non-visible cesarean section, scar, bladder wall interruption, or and then combine those. So subgroup scoring, screening population, the chance is 1 in 1600 roughly, so less than 1 in 1000. If you have a previous history and a low-lying placenta, a previous history of a uterine surgery or low-lying placenta, then the chance between 12 and 16 weeks is 1%. If you have a previous history and still a low-lying placenta when it doesn't have moved away, 6%. If your previous history and low-lying placenta, 27%. That is, I mean, if you visualize in a different way here, you see the chance is increasing, of course, as the placenta is not moving away. So there's another work which has looked much later. In Germany, we have something called like a Geburtsplanung, and there's a nice work from Halle, close to Leipzig, where Professor Chirikov is also working, and they looked, especially because of the high variability later on, how to assess it, even interoperative. So it's a paper I suggest. It's a very thorough design study. It's not connected to the first trimester, but just a hint for you. So and there's another thing. I just reviewed the paper. I hope it will be accepted soon because it shows amazing data from the group of Matsuzaki. Of course, I'm not allowed to speak about that, but I just want to point out you should really think it's promising for the late diagnosis. So the primary title of the talk was First Trimester Screening After Cesarean Section. Let's look at the other pregnancy complications if it is involving any kind of, or let's say if it is a history of cesarean section. From my point of view, has implications regarding any other screening test. You know, this is the Kipros-Nicolaides approach, starting from maternal age, collecting data of maternal history, maternal conditions, having ultrasound parameters, having biochemical markers, and new ultrasound markers, or for instance biophysical markers, and then you will have the individualized risks. If you're a good doctor and your impact as the doctor is the biggest one, actually, in view of an error rate using those algorithms. But if you combine it, and then you have a very good chance of having a highest detection rates and lowest confusion or false positive rates for the patient. So this is a slide from Professor Nicolaides, which has shown it's still evolving. We have moved to 79, 97, 98% regarding screening for chromosomal abnormalities if you implement the ductus venosus, PIV, and also PLGF. And this is true for all. If you look at preeclampsia, I was really happy to be allowed to work on that. The first screening for preeclampsia, Leonard Poon's big inheritance will be the screening for early onset preeclampsia at 11 to 13 weeks. And we in this study, I don't know any impact factor that history of cesarean section has any. What about the screening for premature birth? One of the main topics we looked into regarding spontaneous premature birth, the impact if you do a screening at 11 to 13 weeks using the combined approach of the Wheeler Medicine Foundation. The impact is so far I don't have any impact factor to communicate. If you look at our studies which we did for assessing the risk for so-called potentially detectable defects using the mid-surgery view, in all the studies I performed, there was no impact of the history of a cesarean section at all. So consequences, I think it's amazing what the research over the years of the Fetal Medicine Foundation has shown. And now we need to add this thing we have just learned, the screening for morbidly adherent placenta at 11 to 13 weeks. And I think the data is more than convincing. Thank you very much. If you want to contact me or criticize, please send me an email, robert.lachmann@fetalmedicincenter.de, or you can call me anytime. German access code +49 171 541 9055. I'm more than happy to discuss. Thank you for your patience.